Honour to welcome you to the Society Policy Forum 2025. I'm really excited to be here. We've got a great lineup today. So my name is Victoria Rutter and I'll be your host for today. This forum has always been a space for collaboration, innovation and action, a space where civil society comes together to shape solutions for the health and well-being of our communities. And this year our theme, Fit for Our Commonwealth Towards a Resilient and Sufficient Health and Wellbeing Workforce, is more critical than ever. We all know that a strong health workforce is the foundation of any functioning health system. It's the nurses, midwives, pharmacists, dentists, doctors, social care professionals, and community health workers who keep our societies running, especially in times of crisis. Yet today we gather against a backdrop of uncertainty as significant cuts to international aid threaten the very systems we seek to strengthen. The freeze on US aid funding has left many Commonwealth health programmes in limbo, abruptly halting essential services and creating immediate gaps in care. Meanwhile, the reductions in UK aid have already forced difficult choices, limiting support for workforce training, infrastructure and life-saving interventions in some of the most vulnerable communities. These developments remind us why sustainability and resilience must be at the core of our discussions today. A health workforce that is dependent on unpredictable external funding is a workforce that remains vulnerable. If we are to truly achieve sufficiency, we must explore long-term, locally driven solutions that empower Commonwealth nations to develop, support and retain their own health and care professionals, independent of shifting geopolitical priorities. That is exactly what today's session will address. And as you can see from the objectives on screen, I'm pleased to be joined by an exceptional lineup of speakers who will be guiding us through these conversations. We will begin by hearing from Jim Campbell, Director of Health Workforce at the World Health Organization, who will speak on sustainable financing for a resilient and sufficient health and wellbeing workforce. His expertise in workforce development and health system strengthening will help us explore the global perspective, how we finance, invest and structure workforce policies to ensure long-term stability. From there, we will turn to the future. We've got Professor James Buchan, a Senior Fellow at the Health Foundation, and Professor Lisa Nissen with us, Director of the Centre for Business and Economics of Health at University of Queensland. And they will lead a discussion on planning for a sufficient health and wellbeing workforce for the future. Their work spans continents and disciplines, bringing insights into workforce development, policy implementation, and integration of education and employment strategies. Beyond just sustaining a workforce, we must also recognise the return on investment that comes from a strong health and care workforce. Dr Cornelia Junghans Minton from Imperial College London and Crishni Waring, Chair of multiple NHS trusts in the UK, who is also originally from Sri Lanka, will explore this in depth. Their combined experience spanning primary care, social care and workforce leadership will highlight why considering innovative practice models and supporting healthcare professionals is not just a public health imperative, but an economic necessity. To further illustrate the themes of the 2025 forum, we will then bring these discussions together in a panel discussion moderated by Dr David Jones, featuring perspectives from across the Commonwealth, including from Ravinda Ranan-Elia from Sri Lanka, Rosemarie Josey from the Bahamas, and Zeni Thumadoo from South Africa. Their diverse experiences, ranging from public health policy to frontline workforce development, will help us identify real actionable steps that we as a Commonwealth can take. The aid cuts we have seen are a wake-up call. Many of us are still shocked, distressed, frightened and even traumatised. It may be difficult to think beyond the challenge of today for ourselves, our families and our colleagues, but these upheavals do present an opportunity for us to push for greater national, regional self-sufficiency, stronger workforce policies and innovative approaches to financing health systems, to put people before the politics. So I invite you all to engage, to share and to challenge the status quo, because the health and well-being of millions depends on the strength of the workforce we build today. With that, I'm honoured to open this forum and welcome our first speaker from the Commonwealth Secretariat. Unfortunately, Baroness Scotland was unable to join us today due to her busy schedule wrapping up her term as Secretary-General, but she does send her warmest wishes to us all. Baroness Scotland has been hugely supportive of all our work, and I want to take a moment to put on record our thanks. Her leadership has been essential to recognising the role of accredited organisations and encouraging increased engagement between the AOs and the work of the Secretariat. And as we move forward in this turbulent world of uncertainty, this collaborative effort is going to be even more essential than ever if we are to support member states in reaching their goals for universal health coverage. The Secretary-General has nominated Mr Layne Robinson, Head of Social Policy Development at the Secretariat, to give an address on her behalf. And Layne, I don't know if you're with us today. I know you're travelling, but did you? Yes, you did manage to come. Thank you so much. I know you've had an incredibly busy week, so I'll just hand over to you for some opening remarks, if that's okay. Thank you, Layne. Oh, could you make Layne co-host, please, Chamika, so he can talk?
She's already a co-host.
That's Layne Robinson, Chamika.
Yeah. It's fine.
Looks like he's connecting to the audio now. Chamika, have you managed to do that?
Probably a connectivity issue. Yes.
Just giving him a moment.
Yeah.
Our fingers. Layne, can you hear us? I'm not sure he can join audio.
No.
Are you there, Layne? Maybe we'll give you a moment to connect and we'll move on to Anne, if that's okay.
Hello. Yeah,
No, I think so.
It's
Okay.
gone out. What is this thing? Hello, can you hear me now?
Oh, yes, we can hear you. Fantastic.
Okay. Oh, great. Thank you. Sorry about that. I think you tried to connect me and it just wasn't connecting for a while. So, distinguished guests, ladies and gentlemen, let me thank you for the opportunity to share in this session on behalf of our Secretary General. It's a privilege to join you here today at this important policy forum as we gather under the theme Fit for our Commonwealth. We recognize that at the heart of every health sector, at the heart of the health systems is the workforce, women and men who dedicate their lives for healing, prevention, and care. And that, of course, without them, policies remain just that, words on a paper. And I think in this conversation today, we want to go beyond that. We want to explore the ambitions for universal health coverage that remain, if we're not careful, will remain just that in this new world, just ambitions. Today, we face a stark reality, as Victoria mentioned. Across the Commonwealth, indeed across the world, health workers are stretched to their limits. The pressures of an aging population, the persistent burdens due to non-communicable diseases, the climate-induced health crisis, the long shadow of COVID pandemic still has intensified the strain on our workforce. Many countries struggle with workforce shortages, with burnout, with migration challenges that leave entire communities underserved. And so the question before us as we will grapple with the conversation today is, how do we build a resilient, sufficient, and well-supported health and well-being workforce, one that is not only prepared for today's challenges, but is fit for the future? I think the answer lies in bold collective action. It requires us to invest in training, in retention, and fair remuneration. It calls for us to create workplaces that foster well-being, respect, and dignity, where health professionals are not just providers of care, but are also recipients of it too. Crucially, it demands an ethical engagement with our workforce. This is a matter not just of policy, but of principle, rooted in our Commonwealth values of fairness, human rights, and sustainable development. Health professionals must never be treated as commodities in a global workforce. Instead, we must uphold ethical recruitment practices that protect both source and destination countries. We must build career pathways that offer hope and opportunity at home while allowing for mobility that benefits all. This is why the meeting here today is so essential. The recommendations you develop will help shape the future of our conversation with our ministers of government and our member states, ensuring that the civil society voices remain central to the Commonwealth's health agenda. The experience you bring, the insights, and the unwavering commitment to health equity is going to be essential in this conversation, and we thank you wholeheartedly as a Commonwealth for what you do here. Let this be the moment where we reaffirm our commitment to a future where every Commonwealth citizen, no matter their circumstances, has access to care that they need, delivered by a workforce that is strong, valued, and that is fit for purpose. Together, I believe we are to continue to strive to build a healthier, more resilient Commonwealth, one where no health worker is left behind and where no patient is left without care. I want to thank you for this opportunity to share on behalf of our Secretary General, and I hope your deliberations today will go well. We will be listening very intently to what you have to say, because I believe the conversations you are engaging with today are critical for our health systems going forward. Thank you so much, Chair, and all the best for your deliberations.
Thanks, Layne. I really appreciate you attending in your busy schedule and for those words. And I think you're right, collaboration is absolutely key moving forward to make sure that we have the best for our Commonwealth citizens and that no one is left behind. And I know that you and the team are focusing on some aspects of the health workforce around the Health Ministers meeting as well. So I hope these conversations are useful for that as well. So thank you very much. And I'm now going to hand over to Anne, who is here in person, which is fantastic. So if I just introduce Anne, moving on. I hope you can see my slides. It's not moving. Fantastic. So it's now my pleasure to introduce Anne Gallagher, AO, Director General of the Commonwealth Foundation, to give her opening remarks. And a huge thank you to you, Anne, and just like the Secretary General, you've been so supportive of all our work, and you always come to our forums, and you're always there with those encouraging words. So thank you very much. And yeah, over to you for your opening remarks.
Thanks so much, Victoria, and good morning, colleagues. Am I coming through loud and clear?
You are.
Okay, great. So it's really a privilege to join you once again at the Commonwealth Civil Society Policy Forum. The Commonwealth Foundation recognises this gathering as an important space for collaboration, for learning, and most importantly, for action. It's a pleasure to be with so many individuals who are not only committed to strengthening healthcare systems, but who in their own work embody the very principles of care, resilience, and commitment to advocacy. The conversations that we're going to have today will directly inform recommendations for the upcoming Commonwealth Health Ministers meeting. And as Layne said, and as you said in your opening remarks, Victoria, the key message could not be clearer. A strong health and social care workforce is vital for economic prosperity, and vital for social stability. When we speak of health justice, which is one of the 3 pillars of the Foundation's work, we mean exactly this: financing, planning, and retaining a workforce that can sustainably meet the needs of our communities. So over the last, 5.5 years, I've had the honour of witnessing the extraordinary dedication of midwives, nurses, and healthcare workers across our Commonwealth. You are the ones who stand on the front lines of our healthcare systems, delivering life-saving interventions, supporting families at their most vulnerable moments, and driving innovations in patient care. Your work is not just essential, it's irreplaceable. But dedication and goodwill cannot sustain our health systems. Resilience can't be built on exhaustion. We cannot expect healthcare workers to shoulder the weight of entire systems without proper support, training, and resources. A workforce that is stretched too thin, that's underfunded and overburdened, simply can't provide the care that communities deserve. As the concept note for this year's policy forum reminds us, sustainable financing is essential if we're to ensure a fit-for-purpose workforce, one that's available in sufficient numbers, sufficiently trained, and supported through robust national planning. That's why during every event hosted by the Commonwealth Foundation on the issue of health justice, we've received the same consistent message. Civil society needs is demanding greater investment in the health workforce. Civil society is calling for measures that will ensure that nurses, midwives, and all essential healthcare professionals receive the long-term support they need to continue their life-saving work. In this, as in every other aspect of our advocacy, we must be looking ahead. Forward planning is vital if we are to anticipate future challenges, from the impact of artificial intelligence to the realities of demographic change. If we fail to plan, we fail those whose lives depend on having a capable, motivated, and well-distributed workforce. This year, at the upcoming Commonwealth Health Ministers meeting, which will be focused on investing in health, we at the Foundation and those we work with will continue to advocate for more and better financing for health systems across the Commonwealth, supporting your calls and recommendations as the Health Professions and Partners Alliance. Now, I appreciate that I'm speaking at a moment when the systems and the countries we have relied on most heavily in that regard are taking a firm step backwards. This can be a moment of despair, but it could also be an inflection point for us all to think about what is needed and what the terrible costs of inaction might be. Again, the evidence is clear. A robust health workforce saves governments far more than it costs by keeping populations healthy, productive, and secure. But a return on that investment requires effective retention strategies. The more we do to cultivate a positive working environment, fair workloads, decent pay, supportive leadership, the less likely we are to lose talented professionals to burnout or migration. As some of you might know, this will be my last time addressing this forum as Director General of the Commonwealth Foundation, as my second and final term ends in June. Over the years, I've been deeply inspired. Maybe that's a word that's overused a bit, but definitely not in this case. I've been inspired by the unwavering commitment of healthcare workers and advocates across the Commonwealth. Your courage, persistence, and belief in a fairer and more inclusive healthcare system have left a lasting impression on me and has helped shape the Foundation's own advocacy agenda in very public ways. The strength of healthcare in the Commonwealth will always depend on those who push for change, who advocate for better policies and demand action where it matters most. The Foundation will, under the next Director General, remain committed to amplifying these voices, your voices, ensuring that civil society continues to shape policies and hold decision makers accountable. Thank you. Thank you for the work you do, for the lives you touch, and for the difference you make every single day. It's been an absolute honour to stand with you. Let us continue together to forge a future where health and social care workers thrive, because when they thrive, our entire Commonwealth thrives. Thank you again.
Thanks so much, Anne. That was a very strong and encouraging message. And I just want to reiterate again our thanks to you for standing by us and our cause and for really promoting health justice, particularly at the last CHOGM. And it's really great to see health back on the agenda of Commonwealth governments. And I think COVID has sort of helped that, but also that a lot of the advocacy that you've been doing and everyone else has been doing has really kind of added weight to that. So thank you so much, and we wish you well. It will be a big change having a new SG and a new Director General for the Commonwealth Foundation at the same time. But yeah, we wish you well and thank you for everything, and I hope we can keep in touch with you even though you'll be in a perhaps different role moving forward. So yeah, thank you, and we're now going to move on for the rest of our programme, so I hope you can stay with us. And yeah,
absolutely, I'll be here.
Great, thank you. Right, so I'm going to reshare my screen and I'm going to introduce our first speaker. So it's my pleasure to introduce our first speaker, one who is well known to us, who's been incredibly supportive of the work of the CHPA over the years, Dr. Jim Campbell, Director of Health Workforce from the World Health Organization. Jim, thank you for your presence today. And I'd just like to add that we all stand with you and your team at WHO in the incredible work that you do in these times of uncertainty. I'm really excited to hear from you now. So Jim, I'm going to hand over to you.
Thank you very much, Victoria, and thank you for wonderful opening remarks from Layne and Anna. Pleasure to be with you, and yes, solidarity for health at the moment is much needed wherever we are. So I was asked to just give a few perspectives on some of the current thinking within WHO and how that applies then to the global health and care workforce, the global financing debate, and then bring some of that into the perspective for yourselves in the Commonwealth. I'm going to share just a very few slides just to help contextualize this and then open up for any other elements of discussion. So as we've heard from both Layne and Anne in their remarks, the world is facing multiple challenges around the world in terms of the demand for health, the financing of it, the workforce within it, the burnout, the stress, the anxiety. These are just some of the many, many factors that we are having to contend with, and which the workers around the world are having to contend with. But it is an incredible set of challenges, whether it's across any economic classification, across any geography that's involved. When it comes to the Commonwealth, then, just as you all know, but just to contextualize this, a grouping of countries with diverse context around the world, a mix across economic classification, the small island developing states. We've got migration across these jurisdictions, both as source and destination countries, a lot of intermobility amongst the workforce around the world, up to sort of 1 in 6 now of all health professionals moving from one jurisdiction to another. The workforce of interest in these economies, in these jurisdictions, when we're talking about the health and care workforce, all occupations, all the clinical occupations, the public health, the One Health, the social workforce, understanding the role of local government around water and sanitation, around the economy and nutrition, around housing and poverty, also part of this public health capacity to convince. Not just the big 5 licensed professions, as critical as they are in terms of the volume and the numbers, but all occupations that we're interested in. We have a world, a global outlook, though, which is of huge contrast. We measure for the global perspective, understand we're measuring around the capability of countries to expand health for all to the populations they serve. And the Universal Health Coverage Index, therefore, is a tracer to look at capability, capacity, and to define at sort of international level where there are major inequalities. That's the WHO shortage perspective. It's not the national shortage. It's the level of shortage against Universal Health Coverage Index. And what we see around the world is a decrease progress despite COVID-19. And this is the data that was part of the discussions at the executive board in January. We're seeing this overall decrease. COVID-19 having an impact, slowing the pace of progress between 20 and 2023. So a marginal shift, but not the level as anticipated prior to COVID. And so projections to 2030 suggesting the shortage is growing. So we've got the opposite of the Sustainable Development Agenda, where we're trying to address universal health access, having a workforce that's able to deliver that. We're seeing this dip, this stagnation globally, and then a greater target ahead of us to come further forward. And then also, if you just look at the bottom, the columns in the bottom in blue, the share of this inequality increasingly coming to the African continent, a much greater share of a deficit, a shortage in those economies which are already experiencing some of the major challenges around universalism, maternal health, disease control, etc. So still a real inequality. There is progress, but it's not equal around the world. And at the same time, on the financing discussion, the evidence clearly states, as we build a workforce, as we build the capability and capacity, our operational expenses, our recurrent cost, our wage bill will increase. And so the largest component of health systems capacity, health system strengthening, is that recurrent cost of labor. So we're trying to address a shortage. The more progress we make in bending the curve downwards, the more we increase the recurrent operational costs of wages as the largest component of it. So understanding how these two interconnect, clearly a main issue. So what is the financing trajectory over the last period? What are we seeing as we've shifted into the SDG agenda, as we've started thinking about some of these things? What you can see is that the pattern is not showing a major shift. It's very much a sort of a systemic built-in problem. Marginal increase in the high-income countries and the upper middle-income countries to absorb, to create additional fiscal space and financing to absorb the higher operational costs, but actually regression in the low-income countries around the world. Despite everyone's recognition and awareness that we need to put more money into health financing, we're not seeing that trajectory in the data. So no prioritization in health spending, greater deficit and debt servicing around the world, the post-COVID impact. Many economies now paying more on debt than the combined spending on health and education. That then puts a greater dependency on external sources of revenue, official development assistance for low and middle income countries. It also puts increasing pressure on out-of-pocket expending. And so transferring the burden to access to care to individual seekers of health services. And so that patients and families and individuals increasingly having to spend more money of their income to access health. And then, as both Vicky and Layne and Anne have referenced, we've suddenly then seen this major disruption to the spending on humanitarian challenges, spending on health, on education, on social protection, from the decision-making of the new administration in the United States. Hegemonic policy is one of the, take this phrase from a piece that was published in The Lancet this week about the hegemonic policy and the disruption to global health, global humanitarian programs, sexual and reproductive health that's coming further forward. And what is the impact that we're seeing, this external shock to Commonwealth countries? 8 out of 10 of the Commonwealth countries, 8 out of 10 countries most impacted by the disruption to US aid spending are from the Commonwealth. And in terms of the numbers, considerable share and percentage of total health, government health expenditure from those sources. And already you're seeing ministries having to go immediately into taking out new borrowing, new lending, new loans to offset that external shock. So absolutely, as recognizing this major shift is having detrimental impact on health outcomes, population health outcomes. People are losing their life, losing access to healthcare. We've got mortality and morbidity already increasing in just a matter of weeks in some of these settings as services have been shut down. But then government responses, government borrowing having to kick in. What do we do differently to some of these issues? So as a Commonwealth, if you look at your 56 countries, if you look at the high income, the low income, the middle income, what is the opportunity here to respond to this in the principles of solidarity that the Commonwealth has been built on for many, many years? And just a few suggestions to help strengthen your discussion or to help the panel think and consider your recommendations into the health ministers meeting. The sustainable financing is a critical discussion. We have to rapidly address all opportunities, all revenues, domestic health expenditure, international lending, official development assessments, the role of the private sector. We have to have partnerships with the private sector to really look at how do they pay a share of access to health. Big employers, big industry, co-contributing to public health in a different way. We have to look at the reality in the Commonwealth of the migration and the movements. There are high-income countries in the Commonwealth are not producing enough graduates to satisfy their own domestic needs. And they are recruiting increasingly so. We've seen year after year after year increase from high-income countries in the share of international migration, reaching record levels in the latest round. At some point, we have to recognize there needs to be co-investment, that mobility. There is a economic resource transfer in this global market. And we have to come back to say, let's build a workforce that we can all enjoy and share. What's the global workforce co-investment? And the Commonwealth, as somebody that's got this excellent balance of high income, middle income, low income, with such migratory movement, could be a champion in this space. We've also got to look at the efficiency and the effectiveness of budget spending. On the workforce, we've got to be doing different. There's going to be this challenge that it comes up every 10 years or so. How do we get greater efficiency and effectiveness in the workforce? But a workforce that we know is burdened from the post-COVID stress trauma. that is burdened from shortages, that is burdened from under resources over many years. What can we do with workers representatives, with workers associations, to bring them to the policy table and jointly co-develop solutions around the performance, productivity, optimization of the workforce? Primary care, prevention, public health have got to be the first dollar of investment everywhere. We cannot continue to be ignoring public health and primary care. We've got to, again, bring in the opportunities, the role of other sectors, the public. This isn't just purely a government and public sector thing, but the role of private sector, of faith-based organizations, of not-for-profit, of civil society, to co-develop partnerships that give us universalism, that give us equality and access to come further forward. And really, it's just a huge opportunity and a pleasure to work continuously with this Commonwealth civil society group and the professional group to really say, okay, we know that COVID was tough. The situation now post-COVID, the current decisions from one jurisdiction having this major upset, plus ODA retracting. Our predictions are maybe a 40 to 50% reduction in health ODA in the next 24 months. And in which case, we've got to build the capacity around the world for a much greater partnerships and solidarity to offset that, to look at more efficient services based on primary healthcare, based on public health. Vicky, I hope that was meeting the ask you gave of me, and thank you very much again for the solidarity with WHO. Our focus here at the WHO, yes, we are impacted by some of the decisions that are happening, but our focus is what's happening to the health of the population in countries that are most impacted. That's where we should all be focusing. We may lose a few jobs in WHO. That's not too bad. Maybe we need to be ourselves more efficient, more effective with the resources we have. The focus is on the populations we serve. Thank you.
Thanks, Jim. It's always great to hear from you, and that was really spot on and to time. So thank you so much for both of those things. And I think what's coming through here and in the remarks before is really about the opportunity that we have now to respond to the situation we found ourselves in, and those principles of solidarity and partnership that the Commonwealth is holds so dear. So I think, you know, we've got a real opportunity, and as discussions continue today, I think that will kind of be fleshed out a little bit more. So now I want to hand over to our next speaker, who, let me share my screen. So we've got two speakers now that are going to talk about the vision for the future and workforce planning. So first of all, we've got James Buchan, who's the Senior Fellow for the Health Foundation in London and a visiting professor for the University of Edinburgh, an adjunct professor for the University of Technology, Sydney, Australia. And he's going to be followed by Dr. Lisa Nissen, who's the Director for Centre for Business and Economics of Health, University of Queensland. So unfortunately, James can't join us today. He's on a flight and he was really sad to not be able to be here live, but he has sent a video. So we're going to hear from him first and followed by Lisa. So Charmika, over to you to sort the technology out, please.
Good morning, everyone. Unfortunately, I can't be with you today to present, so this is a recording made a couple of days ago. If you want to follow up with me on any specific points, please contact me on the email address that's currently on your screen. I've been asked to look at planning for a sufficient health and wellbeing workforce, and in the next 10 minutes, I'm going to cover off on 4 issues. Firstly, looking at the policy context, then introducing a policy frame, which I think can help understand the interconnectedness between different aspects of policy and planning. Thirdly, some key points of guidance when developing and implementing national healthcare workforce policy and planning. And finally, looking at a sustainable approach to ensure that there's a long-term viability. So, firstly, policy context. 4 points to cover off here. Really, I'm just stating the obvious in this slide, but it's important to build on this and build on a shared understanding. So, firstly, we're all aware healthcare demand is increasing for reasons of demography, population growth, aging, post-pandemic impact. What this means is that all countries are having to face up to increased demand, and that in turn is putting greater challenges and pressure on the supply of the health and care workforce. And that means planning has to be effective to try and close any shortage gap between demand and supply. It's not only through a national balance of supply and demand. The second point there, planning can also be very helpful in improving access for underserved regions, underserved communities. It's getting the workforce in the right place at the right time, that cliche, to ensure that access to services is there for those who are currently underserved in terms of geography or type of community. Third point there, planning can be very helpful as a mechanism for identifying where workforce investment priorities must be targeted in order to improve population health. So a structured approach to planning, the data underpinning planning can identify the workforce priorities. And finally, there needs to be honesty that planning will not always prevent shortages. There's no perfect approach to planning, but if we have a sustained approach, we can anticipate that there will be a dampening down of shortage or oversupply, and also that the structure of planning will allow us to better identify what the causes of shortages are and be better informed about what to do in trying to reduce them or end them. I mentioned policy framework. This is the WHO labour market framework, which I think is very useful for any planners and policymakers who are working through how to introduce an approach or improve their current approach. What it does is two things in particular. One, it looks at and identifies the different connections between different elements in terms of labour market dynamics, which in order to really look at the planning aspect of that, gives us a good understanding of mobility, of flows, reinforces this point that we're not looking at a point in time, we're looking at now and into the future. And the second point there is this, the lower half of the graphic identifies which policies may be most appropriate, most effective at different parts of the labour market dynamic. So I'd recommend keeping this as part of your framing when you're developing or implementing approach. Third slide, looking at key points of guidance. There are 5 I'm identifying here very quickly. Firstly, there's no magic bullet in terms of workforce policy and planning. We need to be looking at bundles of coordinated interventions across time. And the labour market framework can help in terms of identifying the coordination that we need and perhaps also the sequencing across time that we need. So bundles, not single shots. Second point, clarity of purpose and definitions. I've listed a range of different possible reasons for having planning in that second bullet point. Be clear about which of those or all of those you're aiming for in terms of objectives from planning, because that will help you shape the right approach to planning. Third point, being clear that we are aiming for a moving target when we're planning in healthcare workforce policy and planning. We're looking at a situation that will change, circumstances and priorities will vary over time. That will be to do with internal reorganization, internal policy shifts, the shock of changes in healthcare demand, such as most notably the impact of the pandemic. And also we need to recognize that we're planning for different cycles. So if you're planning for the medical workforce, you're really looking 10 years ahead and more. Much shorter cycles for other components within the healthcare workforce. Fourth point, data limitations. No country has perfect workforce data, but that should not be a limitation on making progress with implementing planning and with prioritising and filling any significant data gaps that are identified. So look at the best use of the data you have, and most countries have more prospects in using data effectively than currently they have, before we look at what other data needs to be developed and generated. The final point there, it's not just a workforce problem that we're talking about. The focus is on the workforce, but we can't just solve the situation by looking at the workforce. We've got to look also at service design, reform, relocation, and effective harnessing of e-health, m-health, and as it emerges, AI. And part of the issue here is ensuring that the workforce has the skills, the trust, the competencies to effectively harness these new technologies as they become more mainstream. I was asked to give brief consideration to the next generation healthcare workforce. And this is a slide from OECD, which looks at the level of interest in nursing as a career amongst 15-year-olds at 2 points in time, 2018, which is the blue diamond, and 2022, which is the pink column. And what OECD identified was that in most of its high-income member countries, there has been a drop in the level of interest across those 2 points in time. This seems to reflect a more general challenge across all health systems about trying to interest and motivate the next generation to give serious consideration to healthcare employment, healthcare careers. And what we need to do here, I think, is collectively recognize that this is a looming and increasing challenge, and it will require investment and consideration about how to ensure that healthcare continues to be attractive and that there is decent work available for the next generation as they come in. Final slide here, and what I'm doing is looking at a sustainable approach. I've got 5 points to cover off on here. Firstly, we need to be clear that we have an inclusive definition of workforce when we're looking at healthcare workforce policy and planning. It's not just about doctors and nurses. We need to extend the scope across everyone who's contributing to delivery of care directly or indirectly. That will also often include community health workers, perhaps volunteers. And the second dimension there is we need to look at healthcare delivery by teams, not by individuals. We're going to optimize the contribution of individuals by ensuring they're working alongside complementary workers with different skills. Second point, yes, we need to talk about new supply, but it's not just about new supply. We need to look at investing in the current workforce to ensure that they are retained and work for as long as they wish within healthcare. We need to provide them with new skills so that they can continue to meet population health priorities and perhaps relocate across to different parts of the health system where their skills are more required. Third point there, when we are looking at new staff and training of new staff, we shouldn't think just about having more of the same. We need to take the opportunity to look at new curriculum, new modalities of training, to provide the right sorts of skill sets to meet future health priorities. And for most countries, particularly that means looking to ensure that there are proportionately more healthcare professionals coming into primary care settings. Fourth point there, which I've reinforced already, adaptive workforce planning, not a fixed and point approach. And finally, using planning to focus on and ensure we get a return on investment now and into the future. Thank you very much.
Thank you, Jim. That was a really clear presentation, and I think it really sets the scene very well for Lisa, who's going to move on and present for us now. So Lisa, I think I can see you.
Great, thank you very much. Hopefully you can see my slides.
Yeah.
Is that yep, great, and you can hear me okay?
Yeah, I think you just need to present, and then we're all good.
Yep. Fantastic. Thanks for the opportunity to talk to you all today. It's such an important discussion having across the Commonwealth and across all of the workforce, as Jim and James have both spoken to. We have to include everybody in these conversations, and all the people that are doing the planning, all the politicians, and all the people that are educating our workforce and involved in all of the decisions. So the presentation I was asked to give dovetails nicely into these, which was to really talk about some of our experience in Australia in trying to deal with some of these challenges. So I'm going to take you through in my 10 minutes a little bit of a highlights tour of where we're trying to look at some future focus and some innovations in this space to meet these challenges. So I think we know that we have a diverse workforce problem, and I think we've had that touched on by Jim, that it's not the same everywhere, and a lot of our high-income countries are certainly drawing on workforces from some of our middle and lower income countries. And I think what we find in Australia is that we have workforce issues that are similar, but different also. We are at sort of the bottom and around on the globe, so we're just a very big island that sits at the bottom. But what we do find is that we have shortages in workforce like other people have. We have an ageing workforce. We suffer from distribution issues. We're a very big country like Canada and America in land mass. So we have a lot of regional and rural areas. About a third of our population live around the outside near the beach, which makes sense. But there's a lot of people that live inside and away from the coastal areas and don't have good access to healthcare or health professionals. We have issues with our training pathways. I think as James touched on. We have issues with people having interests in health careers, and that's why we look to other countries for our professionals. We've had post-COVID, but even leading into COVID, issues with our balance and well-being in our workforce. We're having issues retaining our workforce. People don't want to work as long or as hard as they have previously. For example, in our optometry workforce, the equivalent working hours is no longer 40, it's much closer to 30 hours a week. So even if you have X number of people, that doesn't equate to X number of full-time workers. And what we don't have is a national workforce strategy. So what it comes down to is the fact that we, as Jim pointed to, is spending more of our GDP on health. So that's increased significantly and it's continuing to go up. So we're over 10% GDP. We've got chronic disease, which leading to increasing burden and an aging population. It all sounds very familiar to everybody. But what we are facing because of the aging population, a decreasing replenishing of our population. So our birth rate is much less than it was a number of years ago. We've got less workers, including health workers, to look after us when I say I just I feel like it's going to be me, but we have less workers to look after us as we are getting older. So we have a significant population of older people with a lot less people who are going to be available to look after them. So there's this burning platform in front of us. So this is kind of what it feels like for us at the moment. We feel, that we are at this point where the system is going to implode, much like other people, but we also know that it is complex. I think that Jim and James both pointed to the fact that it's not a simple solution where you just put more money in the top or you stick more health professionals in the other end. There are complexities in how we manage our health workforce within the system and how we manage the system itself. So what are we doing about it? Like all good health systems, we are having a review. In fact, we are having lots of reviews. At the moment, in 2 to 3 years, we've had about 22, 23 reviews with about health and healthcare. And that has meant that we've looked at multiple areas around how we look at workforce, models of care, sustainability and funding. So these are just a bit of a hit list of some of the things that are included in those, but you'll see, interestingly, things that are quite siloed. So we see incentives is in some places, then we see things about nursing workforce, then we see things about medical workforce, allied health workforce, but they're all quite separate. So we see these kind of separate reviews, and we kind of think, well, who's going to pull that all together and make some sense of that so that we actually get some consolidated outcome about how we're going to go forward in improving the system and how we manage it. So overall, we've had some key drivers that have pushed this forward. We had an Australian primary healthcare plan, 10-year plan that came out in 2022, and a review of Medicare, which is our national beneficiary scheme. So that allows us as individuals to go to our primary care providers and have reimbursed funding. And out of that, what the key things that came to the fore were that we need to have better access for sure, but what we need to have is multidisciplinary team funding and care models. It was quite clear that we had very siloed care and we weren't really engaging the full workforce. Obviously, things like digital health, integration across, primary to tertiary care, into aged care. But at the bottom, you can see models of care and workforce optimization were very key points that came out of these reviews, and that we needed leadership and culture change. And I will come back to that in my following slides. But one of the key reviews that I had an opportunity to be involved in, and James was actually a reviewer / consultant too as well, was unleashing the potential of scope of practice for our workforce, primarily in primary care. So how do we look at the incentives and the barriers to get best utilisation of our workforce to their full scope of practice? So it goes to that point of saying not only about retaining the workforce that we've got, but using them to the full scope of what they've been trained to do. So acknowledging that we probably have a whole pile of people that we're not actually funding, providing infrastructure for. We have employment practices that inhibit, there's leadership and culture things that are affecting how people actually are able to work. So I wanted to just draw on a couple of points that were heard throughout those consultations that led to some of the recommendations and things that were of interest for the government moving forward in this space. So there was a lot of things that came out about what can each practitioner currently do and what can they do in the future and what actually affects that. And so legislation and regulation was very key. So we have national regulation for a significant amount of our health professionals in Australia. A lot of the large cadres of professionals are nationally regulated, but within each jurisdiction, so our states and within even institutions, there's different ways that those people can actually then go about doing their day-to-day job. So this whole approach of what is risk and how you actually manage a workforce, even though we have a national scope of practice, becomes a problem. So there's no sort of way of planning and then utilising scope of practice that people have with the incoming need or even the current need. And what became really, really apparent was that there's no understanding or a very poor understanding within sometimes and even between professions of the skills and capabilities across the workforce. So we heard end on end that we don't really understand what physios do or nurses do or pharmacists just do X, Y, and Z. So it becomes very confronting when, say, in COVID, we say, well, actually, all of these practitioners can administer vaccines, and people go, what? No, you can't do that. That's outrageous. Going, actually, they're all trained to do that. And people just went, no, that's impossible. I didn't know that they could do that. So we need to understand who can do what now, but also in the future. So we need to plan for scope expansion and manage that change, but we also have to support that for people. So going to James's point, it's about what skills and capabilities the people in the team have, acknowledging and utilising that skill, acknowledging there is overlap, right? It's like this big Venn diagram, the healthcare team, and knowing that within the healthcare team, we all have our specific things that each profession uniquely can contribute. There is a lot of grey in how we can overlap in our contribution. getting the right person with the right skill at the right time and the right relationship enabled to provide the care in a patient-centered way. Whoops, now I have to move screens. And so what we came out with in the review were these recommendations, that there were 3 primary pillars that we needed to that were underpinning scope of practice optimization for our workforce, that there were education needs, so how we plan and support our workforce. So that was about interdisciplinary training and education and support for working in teams. We also had to look at how we deal with our legislation and regulation, but we also had to look at funding. But one of the key things was how we built a national skills and capability framework and matrix to really rise up and acknowledge this space around the shared skills and capabilities in our workforce, and then how we can use those effectively to operationalize all of these other recommendations. But a key part that you can see at the top in gold is leadership, culture, and governance to support that. So it's nice to have recommendations, but if you do not have the leadership and culture change to do it, it's just another report and just another lot of recommendations. So if you can see how this really feeds in and comes together and how we're looking to move this forward at the moment, the key ones that we're looking to start with as implementing priorities, noting that building a skill and capability framework for the country is not an easy task. And the independent evidence mechanisms that would sit under that. So you're going to say, here's a model of care, here's this great thing that we're going to do. We want to use this practice in this space. We want to use the skills and capability framework, and we want to remove the turf wars and the barriers around this is how we do it and whatever. We want to build an independent process that sits underneath that uses the matrix to make things happen. That is the key thing that will fit with the matrix, and harmonisation of our drugs and poisons regulation are the 3 recommendations that they're moving forward with at the moment as their first steps. So we fit all of those into the questions around models of care and optimisation, how we fund and support our MDT teams, and the leadership and culture change that we need to make to help our workforce be able to provide patient-centred care in an effective way. So it's a big piece of work and there's still more work to do, but it's a big step towards taking a needs-based approach to workforce planning. Thanks very much.
Thank you so much, Lisa. I love hearing about your work, and I think it's a really encouraging step for Australia, but also it could be used as a really great blueprint in terms of how you've approached this work, looking at a needs-based approach for other countries as well, really helping them to think more outside the box. And I love that sort of Venn diagram that you've produced there, showing the overlap in the skill sets. So thank you so much. I know you're joining us for the panel discussion a bit later, but we're a little bit behind time, so I'm going to move swiftly on. So our next 2 speakers are going to be talking about return on the health workforce and some innovative practice models. I'd like to introduce firstly Cornelia Junghans Minton, who's a Senior Clinical Fellow in Primary Care and Social Care Lead at the School of Public Health, Imperial College London, and she's going to be followed by Crishni Waring, who's the Chair of Northampton Healthcare NHS Foundation Trust. So I think we've got Cornelia here, is that right?
Yeah, she's got my name, Victoria, instead of her own.
Well, I was wondering if there was 2 of you, Jill. I know you do a lot of work and there might need to be, but
I'd like her long blonde hair.
I don't know if I've lost my stop share. There we go. Over to you, Cornelia.
Thank you. I can't see my slides at the moment, but I'll crack on. I don't know if you're going to put them up.
Tamika, have you got the slides to share there?
But just to say, I'm Connie, I'm a GP as well as a clinical senior fellow, and we heard Lisa talk about the right way, the right care, the right way, in a personalized way for the patient in front of you. Also, we heard a lot about sort of the problems we're facing and optimization of assets. So I want to talk today about return on investment from a sustainable and happy workforce. So I want to focus particularly on the community health and wellbeing workers based on the Brazilian family health strategy. I don't know if my slides are going to be coming.
Yeah, Chomika, have you got the slides? Can you hear us?
I'm going
Or
to try
do
and
you-
share them from here.
Yeah, if you do have them, maybe that's, I'm sorry about this.
Do you want me to put them up
Can
and
people
then
see, can people see my slides?
Yes, we can.
Okay.
It's
you
a-
can see them? Oh, good. There they are.
So hopefully I can move them on. Can everybody see the slides moving on?
Yeah, if you just maybe
Yeah.
put the present mode so that we can see, that's it. Thank
Oh,
you.
well, and it's moving on. Yeah. Okay. So we heard about all of the issues earlier today. It's no different in the UK. So the issues faced by the NHS are around workforce, driven by medical advances, aging populations, etc., low job satisfaction, high turnover of staff. Our services are fragmented. The UK is underfunded in terms of healthcare, but despite that underfunding, there's also quite a lot of waste in the system. We have differing experiences and quality of care. The health inequalities are rising in our country, driven by unmet and unknown need. So how do we find cost-effective, sustainable and effective solutions? And I want to highlight these three things. We know that 80% of our health is determined by where and how we live, and only 20% is determined by timely access to high quality care. So we focus a lot on like, how do we get access to better investigations, better drugs, better procedures, but actually if all of that was perfect and we had immediate access to the best care, that would only determine 20% of our health. We also know that we're not always measuring the right things. So we measure whether somebody smokes or not, and we invest in smoking cessation, but we know that loneliness has the same impact, if not worse, on heart health, but we don't measure it because it's difficult to do and it's even more difficult to rectify. And we also all know prevention is better than cure. So how do we pivot to prevention and health creation, which we need globally? And I'm going to turn this around a bit and actually look to the world. So this is from the Community Health Impact Coalition. We heard community health workers mentioned earlier, but they always feel like a bit of an afterthought. And we know that community health workers work. And there's plenty of evidence on this website from the SHIC. But I want to focus on particularly the Brazilian family health strategy, which in my view is the gold standard of community health working and might present this solution to right care at the right time. So we distilled, I can hear a bit of interference from Shamika, I think. Somebody, if you mute yourself. So we distilled this down into 4 principles, which make the Brazilian family health strategy so effective. So it's comprehensive at the household level, hyperlocal, so people from that community for that community, universal, everyone gets seen, but proportionately universal in that wherever need arises, more effort is directed, and it's integrated with primary care and the local authority and the community sector. And apologies for any Dutch people on the call that I misspelled Netherlands, but these are the locations where the Brazilian model of community health workers is already being implemented. So South Africa, Netherlands, and Belgium, and the UK now. So we've started with 4 community health workers who were allocated 120 households each in a very deprived population in Westminster, in an estate with 500 households. It's now propagated to 25 locations in the UK. So we've got 124 community health workers, and you can see some of them in the picture. And I'm not going to dwell on this, but they're clearly effective. In Brazil, we have solid evidence that in the 30 years that they've been working there, they've been linked to a 34% drop in cardiovascular mortality, 31% drop in stroke mortality, increase in breastfeeding at 1 year, increase in perinatal outcomes, better outcomes, a decrease in racial and horizontal inequity, and many, many more. And in the 3 years that we've had this model in the UK, we have a 7% drop in unscheduled GP visit after 1 year. We've got 90% improvement in well-being. We've got dramatic increase in the likelihood of vaccinations and cancer screening uptake and NHS health checks. And we've got a return on investment of £4 per pound invested in the most deprived areas. The top issues of concern are not health, physical health. They are finance, housing, mental health, loneliness, food security. And it takes work. So we have 11 door knocks to secure 1 visit. So it takes a lot of time to build the trust, but once the relationship is built, it works really beautifully. We give them lots of training. And this is key. So they are recruited on character, not on characteristics. So they don't require any skills, but they have to be people from their community who are passionate about their community, who are emotionally intelligent, culturally competent, good team players, good listeners, good communicators. And then we integrate them in the system. So they're part of the GP practices, they are part of the voluntary sector, and they hold coffee mornings for their residents once a month. They're often themed around medical issues or social issues. And you obviously also need the system to wrap around them. So they're only as good as the people who they can connect other people with, because as I said, they don't bring any technical skills. So this is the Octopus Integrated Neighbourhood team in Westminster. And for anybody interested, I've sent Jill some resources that we can you can access afterwards to find out more about it. But it's basically all of the frontline roles in Westminster having a relational approach to each other, where we empower people to pick up the phone to one another and be flexible. So what are community health and wellbeing workers? As I said, they're local lay people trained, employed and integrated, and that's really important. They're trusted contact who can personalize care and advocate for their residents. They're persons who can involve other professionals, work alongside us GPs. They're good listeners, communicators, a bridge between unskilled and skilled work. What they're not are, they're not gatekeepers. They're not barefoot doctors. They're not medical. They're not a cheap alternative to technically skilled workers. So there's often a temptation to kind of load things onto them. Like they can take blood pressures in the community. They can do cholesterol checks. They can do dementia screening. And of course they can do all of those things. But the important thing about them is that they're gender free. Fleur de Meyer, who is a GP from Holland, calls it precision community medicine, and this is what it is. It's starting with a household and saying, who can I bring in who is right for that family and who's available and who can help. They are also not volunteers. That's really important, that they are it's to keep them safe. And to keep the residents safe, they have to have a mandate, they have to have some kind of safety net around them, they have to have other professionals they can lean on. And they're not just a stepping stone into higher skilled roles. So the job satisfaction is really high. In Brazil, we were in touch with Brazilian community health workers who've often been in place for 20, 30 years. So why do they work? They work because there is one person coordinating. So we heard about optimization of assets. They reinvigorated my joy of being a general practitioner, because I work alongside them. And so they bring in the right people. They coordinate services. They are hyper local, so they have proximity to the local language. They understand the neighborhood, and they invest in their own community. They're universal, so they find unknown and unmet need. You heard about the 11 door knocks. They have flexibility and agency. That's really important. They're integrated, so they build a team around the resident rather than being lone workers sort of dealing with everything themselves. And they're proactive, so they catch people when they're falling, not when they've been on the floor for a long time. Job satisfaction, we hear, is really high. They say they have a sense of purpose and pride. They contribute to their own community. They utilize assets better themselves. They learn on the job. They work in teams who they lean on support for pastoral care as well. They have agency, belonging and control, and that's really important, that they have a high degree of autonomy. They're able to direct their efforts where needs are greatest, but for that reason, you also have to integrate them well, so that there is safety in the system and resilience. And there's parity of esteem, so they're local experts valued for their insights. The impact on the community is not to be underestimated, and we do some research in that as well. So they increase connectivity between members of the community through their coffee mornings and through their regular once a month outreach. They start focusing on similarities rather than differences, and they change hearts and minds. Top tips for propagating this model is don't scale it in the way that we like to scale, where we kind of like set out parameters, but locations have to be ready to want to do this. Everybody has to have buy-in. I mentioned ABC, building trust is really important, and we need to measure that as well. Enable cross-locality learning. So we're learning from Brazil. We're learning between the 25 localities. We have a community of practice. A flat hierarchy is really important. Getting used to polyphony, which means listening to many voices in the room and different ways of expressing themselves, and mutuality. So think long-term and sustainable. And I'm going to stop here. I know we're over time, but I'm happy to take questions.
Thank you so much, Connie. I think I love your model, and it really caught our attention when we saw this research, and it's great to see you know, a model that's being used in Brazil, which is not a high-income country, being implemented here and with such fantastic results. So thank you so much. I think you might be staying on for the panel a bit later, but we need to move on now to Crishni. So Crishni, over to you.
Good afternoon, everybody. Let me just get some slides up and hope that I can make that work. Optimize for video sharing. Sure. Has that popped out?
Yep, we can see that. You just need to hit.
Great. I just need to go back. And does that work?
Fantastic. Perfect.
Great, thank you. So good afternoon, everybody, and thank you for the invitation to join you today. I'm hoping in the course of this presentation to illustrate for you the approach that we've taken in one of the organisations that I lead as chair to developing a really strongly engaged and therefore more resilient workforce, and one that really then wants to continue to work for us, so retention, and be part of the journey that we've been trying to take to deliver outstanding compassionate care, which is the ambition for the organisation that I chair. So by way of context, this organisation provides a range of physical and mental health services in both hospital and community settings, including people's homes, and in secure settings such as prisons. So very diverse set of services in a lot of different settings. And actually our staff therefore don't work under one roof, they work in lots of different parts of our communities. And therefore the approach that we took to really supporting our workforce needed to reflect that. And we have about 5,500 staff. So this is a relatively localized example, but one that really I hope will illustrate the sort of difference that the investment in our people has made. So we've been on what I would describe as a 10-year journey. I know that sounds like an incredibly long time, but I think perhaps understanding that a big focus of this was about culture, and changing culture isn't a quick fix, but an important journey which I happened to join in November 2016, and when we started that journey, the organisation was very much at the stage of needing to improve its quality of care. It was rated as requires improvement, which is the single sort of, description ratings that our quality regulator uses in England. But also we were not financially viable at that time. We had a significant reliance on temporary staff, which I think was problematic as well, because obviously affects quality and of course cost. And our staff engagement was not as strong as it could have been, and we certainly felt that needed improvement. So we started thinking about how we would address that, and our focus, which I think is, I wanted to connect to something Lisa said earlier, and happened to join as she was talking, that she emphasized, I think, 3 areas: leadership, culture, and governance. So our focus around this was on leadership and culture, very much on establishing the kind of leadership approach and improvements in our culture that really would create the right bedrock for improving performance, and really recognizing that that was part of the picture that we needed to address. And the quote here that I don't use quotes very often, but the one that always appeals to me is the culture eats strategy for breakfast. And I think it's that recognition that you can have the best strategy for healthcare in the world. You can have great ambitions for what you want to do, but if you haven't got the culture right in your organization, recognizing, I think what was said earlier in the previous presentation, obviously, you know, the wider determinants do say that only 20% is about actual healthcare, but nevertheless, to really have an impact on our communities and make a difference, getting the culture right in the organization really does matter. So that was the focus of much of our energy. And what we really started to think about in terms of our challenge, recognizing what I said earlier about this is a community-based organization with people based all over our community, and not necessarily under one roof in a hospital. We chose the approach of distributed leadership, and in very simple terms, that was really about recognizing that everybody in our organization needs to be a leader. It's not about people like me sitting on a board around a board table and our senior leadership team. Yes, of course, we set the tone, we make decisions, we invest in our organization, but the people who can really make a difference to patients and the communities we serve is our staff. And it's people everywhere in our organization, therefore, that we need to support to make that difference. And so the concept of distributed leadership was adopted. And then our focus was on how do we actually start making that change work. So the change was very much about developing people's confidence and capability to take on that leadership role, irrespective of your seniority or your status in the organization, and the kinds of initiatives that might help people, all our staff, to really respond to the challenge of distributed leadership. We started by actually co-producing with our staff the leadership behaviours they felt were important. And the slide shows the 4 that we chose. They could be different leadership behaviours for different settings, but the ones that resonated with our staff were about working together, taking responsibility, being authentic, and embracing change. And those aren't just words on a page. They are now embedded into our processes for appraisal, for selection, for communication, for training, etc. So, and there are examples of what good looks like for all of those leadership behaviours in the development work that we do with our staff. And when I'm recruiting for board members, these are the behaviours that we look for from our board members. So there is a real sort of tone throughout the whole organisation. And some examples of the initiatives that we've used to support that development include leadership conferences. Now, importantly, these conferences were not just for people who have line management responsibility. They were open to everybody, because if we say that everyone is a leader, it doesn't matter what your role is, you should be able to come to a leadership conference. So they were open to everybody. They happen quarterly, they still continue, but they started initially on exploring the different leadership behaviours. We've had conferences that enable people to contribute to strategy, a whole set of topics, as you will see there. But also to promote safety, including psychological safety for staff, so they feel able to speak up and share their concerns, to promote diversity, to promote well-being, and more recently, to really encourage compassion, not just to patients, although obviously that is highly important, but to each other and to themselves. So how do we encourage staff to be compassionate towards themselves and to colleagues, as well as our patients? And more recently, we've been running conferences for people like our admin staff, people who play a really important role in supporting the clinical colleagues who sometimes don't feel they have the same role and importance in the organisation. And these conferences have tried to emphasise that. Another example is our leadership development programme, and this is very much encouraging leadership development for people who have line management responsibilities, because clearly it's very easy for me to talk about the right kinds of leadership, but we need to equip people to demonstrate that and demonstrate the right leadership approach when they're in line management roles. So that's another example. And then alongside of that, a number of other initiatives, such as recognising staff for their contributions to the organisation, everything from supporting equality, diversity and inclusion, giving the best patient care, being a great leader, working within a team, collaborating with partners. These are all things that peers and patients can nominate staff for, and those recognition arrangements operate throughout the year. Yes, we do have a big annual event, but they also include other apologies, you may be hearing some background information. My dog barking in the background, I'm not sure, but hopefully that stopped. So yes, very important that recognition plays a part, but also encouraging staff networks to promote and support equality, diversity and inclusion, and make sure that staff feel they have a voice, and the particular needs of our ethnic minority and cultural minority staff, or our LGBTQ staff, or our staff who have responsibilities to care for others or who are disabled, they all get strength in being part of a staff network and are encouraged to use their voices collectively. We focus heavily also on staff wellbeing. We have a wellbeing steering group, which includes staff network representatives and includes union representatives, and really helps us to prioritize well-being. And actually that's just, that includes helping people to look after themselves, to seek help, and also to make sure that people understand what support is available to them. So all of that really is about addressing, our staff engagement and making a difference to how they feel about their working relationship with us. And you'll see on the slide some examples of things that we feel we have been able to improve as a result of these investments. We've significantly improved our staff survey results over the years, which is a standard NHS approach. We're now near the top of the upper quartile for performance against the staff survey, but importantly, our retention rates have improved, our vacancy rates have gone down. We improved our quality to be rated as an outstanding organisation by our quality regulator, and have maintained a good financial track record. So finally, just to finish, I strongly believe that the investment that we've made in supporting our people and keeping people engaged and feeling valued has been worthwhile, not just for us as an organisation, but most importantly for the communities we serve and the patients we serve. So I would absolutely support the premise that a happy and healthy and cared for workforce, both health and care, and in whatever setting they are, can make an absolute difference to the care we provide and bring wider benefits to the society at large. Thank you.
Thanks so much, Crishni. That was really insightful. And I think coming through loud and clear, both in your presentation and in Lisa's, is the absolute importance of leadership, culture and governance. And we don't just need more of the same in terms of we need more numbers, we need that as well. But without this, it's like a leaking sink, isn't it? We're plugging in the water and it's just kind of leaking out the bottom, if you like, so faster than we can fill it. So I'm going to pick up, I think we will pick up some of these points in the panel discussion now. We're a few minutes behind time, so I'm going to swiftly hand on to David and just introduce our panel. So thank you so much, Crishni. And I will now move on to David.
Thanks, Victoria.
Right, David, I think you've got Lisa who's coming back to join us. And did you want to introduce the rest of your panel?
Yes, well, for time, the information is in the programme, but we're really pleased to have Ravi from Sri Lanka and Rosemarie Josey from the Bahamas and Zeni Thumadoo, who's in South Africa, who all have got different experiences and things to share. We haven't had a lot of questions in the chat, but I have got questions for each of our panelists. We're going to have, I'm just looking at the time, we've got just under half an hour for this. So there's a question to each of the panel members, and there hopefully some opportunity for some conversation. Is Zeni there? She's not on my screen. Have I not got enough people on my screen?
She's there, but I don't think she's got a camera on, so I don't know. Yeah, there we go.
Zeni, hi. Great to see you. So we as a panel, we come from all sorts of different backgrounds. And I'd just say after Krishni's presentation, it's really encouraging to see that really good staff workforce management and really good culture actually improves things. So many managers think you've got to be nasty to the staff to make them better. And let's get rid of that stupid idea now. If you look after your staff well, you keep them and they work better and your public is better impressed with the service you give. And if that's one big thing to come out of this, and that applies in whatever circumstances, and treating people better doesn't mean that you don't pick up bad behavior or poor practice. Treating people well means you do identify poor practice and you deal with it with training and, if necessary, with other things. So it's not soft. It's really hard to treat people well. But let's dive straight into some questions and to go round. If I go round, colleagues, and if after somebody has responded, you want to, one of the panel members wants to chip in with a quick comment, let's hope we've got time. So the first question is going back to Lisa, and I suppose, Lisa, it's a real challenge. Many of us who work in this, we look with despair at our governments. Why on earth don't they do it better? Are they really listening? Who are they really serving? So why is it that things don't work when we're doing planning? Can we have confidence in planning? And perhaps how can we as people influence that process a bit better? But Lisa, sorry, rather big questions for you there. Any comments?
Yeah, no, thanks, David. And look, I think it is a big question, but I think we'd all agree that we're often affected by election cycles in our various governments, either nationally or at jurisdictions, and sometimes not in sync and out of sync. And short-term planning is the evil in some of this as well, that nobody is interested in investing sort of in the longer term planning that I think James talked about, that 10 or 15 year plan that you need to turn the Titanic around when you've got to look at, pivoting policy or education or culture to actually affect some of these changes. And I think what we do know from our own experiences is that we're very siloed in how we do this. I think the list of reviews that I showed you showed that we're doing that. We're looking at medicine workforce, and we're looking at nursing workforce, and we're looking at allied health workforce. But those workforce reviews are not actually talking to each other. And so we go on this, supply demand approach, which is based on previous use of the workforce rather than thinking about what is the need and the multidisciplinary and team models of care about that right person at the right place at the right time, and planning that way, because it's actually hard and it doesn't fit with election cycles. But in contrast, I think the way that we can motivate that, and where we do get change and where we get policy-based windows that we can walk through, is often because patients drive politicians, and practitioners drive politicians to affect change because it lets them continue to get their seats. And so I think that's getting them to vote with their feet, about wanting to support better workforce to help them have better healthcare, and all of the things that come with that. So we have to have patients be our best advocate, because I think if we do it from the other end and we make it about us, we won't necessarily get the same traction.
That has a lot of resonance. Alliances between the people who use the service and the staff, and to have the confidence to keep going. Just because you're knocked back doesn't mean that you give up. And particularly at the moment, that's an issue. I don't know, Rosemarie, do you want to come in on that as a reflection on how we can influence the process, and perhaps then come to Zeni? I'm just looking for Ravi. Is Ravi around in the? She's not on my screen. But Rosemarie, do you want to comment on what Lisa was saying?
I just want to interject here that when we look at our Commonwealth government, in order to retain an investment in the education and the employment opportunities of our workforce, there are some strategies that government have to adopt to maintain the welfare of our nurses. When we look at the State of the World Nursing Report in 2020, that report serves as a critical resource that sheds light on the global nursing workforce and its indispensable contribution to health-related objectives, especially in the context of the Sustainable Development Goals. This report also identifies some of the challenges that nurses face in the profession, including the migration of healthcare workers, the gender inequalities, and the need for increased investment in the nursing sector. And how do we encourage our government to retain their health and social care workforce? It is so very critical for that enhanced collaboration among our Commonwealth governments to adopt the policies that were recommended through better workforce planning, investing in the education and training of our nurses and other health and social care workers, as well as to improve the working conditions in order for us to retain our nurses. And they must commit to developing our nurses. And some of the effective strategies that was identified on this forum today is when you look at the competitive compensation and benefits for nurses, they must offer attractive salary packages that have included comprehensive health benefits, retirement plans, because many of our working nurse force are getting older, and this bonus can significantly enhance our job satisfaction. We look at creating work-life balance that encourage flexible work schedule, remote options, and adequate time off that helps prevent burnout among our staff and improve the job satisfaction. We look at a positive work environment, cultivating a supportive workplace culture that promotes teamwork, respect, and open communication. And this can help retain our staff as well, recognizing and celebrating achievement that will foster a positive atmosphere. We must engage our nurses, particularly in soliciting feedback through surveys that would involve employees in decision-making process that can create a sense of ownership and belonging. And we recognize that once our health force have this sense of recognition within their organization, they will feel value. We look at addressing leadership development. This ensures that our leaders and managers are trained in effective leadership style that can lead to better support for their staff and a healthy workforce environment, and building activities, organizing social events, team building exercise, community outreach programs, and all of these can strengthen relationship among the staff and enhance a working morale. And because of the fact that when governments commit to developing and implementing these effective retention strategies for their health and social care workforce, we will have a healthier workforce, one that is very effective, that we can retain.
Thank you, Rosemarie. And a lot of that resonated with what Crishni was saying about the way that staff are managed. That's a key message to come over. If people are not happy in where they're working, they'll find ways to leave. Not always that everybody has ways to leave. Many people don't have that flexibility. Zeni, could I come to you next, because you've done some pioneering work around particularly youth work, social care, linking in with health in South Africa. And you'll tell us about the name, is it Bindi, is it, approach which you've been developing. So how can governments be encouraged to consider innovative models of service delivery that recognise the importance of looking after their staff? That's something I know you've been working on. Zeni, over to you.
All right, thank you very much. Just to say that child and youth care workers, the field that I represent, are child-focused direct practitioners that work in the life space of children and youth and families, providing developmental care and therapeutic work while their lives unfold. Child and youth care workers traditionally in South Africa worked in residential care. But we've developed models that demonstrate the role of child and youth care workers in other settings with children and families in communities. So it's a community-based child and youth care work, in educational settings, in justice as social intermediaries in the sexual offences courts, and also with youth seeking employment, providing the kind of oversight and mentorship that is required. So just to say that the Izibindi model was a model that wanted to demonstrate the role of child and youth care workers in communities and families. So we went to localized communities and in partnership with local communities, recruited and trained and provided accredited training to unemployed women and youth in order to develop them into child and youth care workers. And we deployed them with local partners, local organizations to work effectively in communities. It was very much a home visiting program. It was funded initially by the funders and government saw the value of the program and saw the need to scale it up. So we designed the model as a scale-up program, and I know one of the speakers talk about propagating, and I think in many ways that was a lovely word because it actually helped me understand that is, I think, what we were doing. So we scaled up the model, like you might say. It looks the same wherever you go. Everybody gets training and it's implemented in the same way, but it was also very sensitive to local needs and local culture, ensuring that the model infused a unique, localized way of responding to children and youth. We were aligned to the model to government priorities, and government priorities were priorities that we were sure were in the best interest, of course, of children, and made sure that the model implemented government policies, government legislation. We made sure that in the scale-up of this model, we worked closely with local stakeholders, the local leaders, the local traditional leaders, and other stakeholders and funders that were interested in those communities. And in that way, we were able to bring additional resources and funding to the work that we were doing. So, for example, if we were working in a mining area, you'd find De Beers or Anglo-American interested in funding a project. Or if you're working in a fruit farming area, you might, or wine farm, this is the South Africa I'm talking about, you would look at those types of funders that could align their funding to scaling up and supporting the development of the model. I think that important in the stakeholders is what we were talking about today, is a diverse, is multidisciplinary work, working together with others in the sector, health workers, social workers, child and youth care workers, working together in interdisciplinary teams, intersectorally, to respond to the needs of children and families. I just want to say as well, it's important to have a national footprint in a scale-up of a model, because the way government funds is that through Treasury, you get national funding, you get provincial funding, you get localized funding. So it's important to see that you can access all sources of government funding as much as you're looking at donor funding. Sustainability is quite important in the design of a model. So just to summarize, what we've done is that we've designed a workforce so that government would be interested in it by looking at government priorities. For example, unemployment was a crisis. So we responded to by scaling up a workforce to the unemployment crisis. Skills development was a need. So we developed a skilled workforce locally. Women empowerment was a priority in South Africa. So our workforce is an 80% women workforce. Youth employment was a strategy. So we made sure that youth were included in the recruitment process. Youth in South Africa, by the way, is defined as anybody to the age of 30. Rural development was prioritized because this was historically disadvantaged communities in South Africa. So we gave attention to selecting rural development opportunities in our program. Child protection services to children, a priority. And of course, we saw it at the national scale up. So what happened is that government decided to have a ministerial initiative to scale up the Izibindi program. They provided funding in partnership with USAID and other funders for the training of 8,000 child and youth care workers nationally. We developed in that process 400 local partners to manage the programs, and we served more than 1.9 million children in the 5-year of scale up in partnership. We were trying to present a business case for the deployment of child and youth care workers at early intervention level, responding at community level, and prevention and intervention. And government obviously bought into it. They have since then adopted the model. The value of childcare workers is recognized in our Children's Act and other policies and legislation. And we, I think, contributed to the development, deployment, career pathing of a child-focused workforce in South Africa through the model. Thank you.
That's really, really impressive, Zeni, to see the connections between focusing on what the government was wanting to do, but also using skills, connecting with the community, which what Connie was talking about. We talked a lot about the culture and the understanding. I'm just wondering whether, Lisa, you might have some reflections on this challenge for the health workforce. It's been picked up in some of the questions that there's traditionally been such a focus on the high-tech medical demands. And of course, the public are demanding that. They want their cancer treatments. They want to have health, heart conditions. There's more and more complex medical procedures that become available. But on the other hand, we know that to improve health, we need to work on housing and poverty and have the community connections, which Zeni and Connie are talking about. How do health systems balance those demands? The politicians so often go for the spectacular, and they've consistently missed the things that really help the majority of the population. Lisa, is that a fair way of putting it?
It's another big question for me. I think you made the really good point about announceables. I think it's really great to say we're going to fund a new MAB for cancer treatment. Yay, look at us. But the millions of dollars for the treatment could have been put into a preventative campaign for smoking, or improved nutrition or food security, or other things. And I think we've seen systematic disinvestment in public and preventative healthcare and staff to provide that. I mean, in our own country, a number of governments, or a systematic approach from governments over the last decade to 2 decades has meant that our departments and areas in preventative care have been gutted. And that played out in a horrible way when COVID came, and we had nobody to actually enable in our public health response. So I think I think that will continue while we base our planning and processes on election cycles. And that's how people get re-elected, by popular demand, which will be a problem. And I think that's why we have to go back to driving. And I think we're seeing a change. I think we're seeing, the power of the people, for better or worse. We're seeing that politically across nations at the moment, and that's who's getting voted into governments, for better or worse. That might look not great in some countries, but the power of the people will be the thing that drives the change. And so where health and healthcare becomes more and more important, that's where it'll become a problem.
Populism is concerned about the health of the people who are there. I know, Connie, you were saying it isn't an either or. We're going to have to wind up. I'm just looking, we've got a few more minutes, but and I would also say, Connie, I was a little upset when you said that the technical skills, networking, and as a social worker, networking, making connections with communities, those are highly valued and actually very rare skills, and we need to celebrate those alongside the medical diagnostic skills and so on. But anyway, sorry, I came back on that.
I couldn't agree with you more, David. And I think by low technical skills, I mean the kind of like the skills that we value as technical skills, doing the central line and things like that. But absolutely,
in the health sector,
kind of soft technical skills that are really, really valuable, and absolutely, this is the key.
And that's one of the issues for health and so on systems, is what skills do you value? And the skills of relationships and dealing with loneliness, and those are skills that are not often so recognized, although bedside manner is classically in the health sector. Sorry, I'm letting my social work culture coming through there, but that's part of the conversation we've got to have. Last run round the panel, final comments, and then we're back to Vicky to wrap up. Rosemarie, coming to you in the Bahamas, do you have a final sentence or two to share about how the systems can support nurses in your context and health and care workforce, and keep people in their organizations where they're providing good support? Any thoughts, Rosemarie?
Yes, I just want to include that when you look at the migration of nurses, and you realize that for many of us, our countries, we will face workforce shortages. And it's the same thing for us in the Commonwealth of the Bahamas, where our nurses are migrating for better opportunities. So if you think of ways that we can retain our nurses from the need to migrate, to increase their benefits and involve them in the decision-making process and make them feel value, we could retain our nurses by offering them special bonuses to help retain sign-on bonuses, especially for those areas that are highly specialized, because there is a need for that. And many of our nurses, they don't want to really migrate to other countries. But if our government could see the need to really invest in the education and the training of our nurses,
right,
to burn it out and make sure that we have the proper ratio of staff to patient, we will retrain our nurses, as well as we invest in the technology as well.
That's right. There's a cost of not doing things, and the cost of not looking after staff is that you lose them and you have to train new people, and it's not good. Final few comments. Lisa, would anything you'd like to add? You've already given us a lot.
Yeah, I think to the point that you made, Rosemarie, I think we have a significant underutilization of our current workforce.
Yeah.
You know, recognizing that our nursing workforce and medical nursing pharmacy workforce are all really important. Each of them are underutilized in what they're currently allowed to do. And I say allowed meaning funded to do, policies, culture, the whole thing. So, you know, being able to actually look at what our current workforce has the capability to do and utilizing them better makes them feel better valued, retains people in the workforce, you know, saves us having conversations about training more and more and more when we're actually just not using the ones that we've got as effectively as we can.
And it isn't only money that keeps people. Training, recognition, supervision are really important, and as well. So those things are crucial. Just very, very quickly, Connie, and then Zeni, have you got any a last comment?
Yeah, I'd just say giving people agency, that's the key thing for me. The like you say, it's not about money, it's about belonging, agency and control, and fostering that, making space for that, having less of a hierarchy. That's the thing, and also particularly sort of learning from all the assets that are out there. So particularly in this forum, you know, there's so many sort of frugal genius innovations that we don't consider across the world because they come from low and middle income countries, and kind of widening our gaze and having bi-directional learning is really important.
Yeah. And as Crishni said earlier, there was an example there. I know it personally, that they turned an organisation around that had financial problems, had staffing problems, by making sure everybody felt that they were leaders, recognising everybody had a contribution to make, engaging everybody. Zeni, which is what you've been doing, and connecting with communities as well. You've got one sentence.
Okay, I think I learned from the Global Social Service Alliance the importance of carefully planning a workforce, carefully developing a workforce, and carefully supporting a workforce. And I think in that lies what you've basically said: the training, the supervision, the working conditions and salaries, the regulating a workforce to give them a status, and creating that sense of belonging with them. I think localized workforces are very important, and that's where the planning is appropriate, because people who come from local areas are able to infuse their culture, their language, the appropriateness of the profession you're bringing in. And in that way, you retain historic good values in the context of professionalization. Thank you.
That's a really powerful ending for a Commonwealth webinar, recognising diversity, Indigenous perspectives, and all of the local values. And perhaps a key message that if you recognise that staff are there wanting to do their best, they've got things they can offer, talk to them, listen to them, don't bully them, you'll get the best out of the workforce. Vicky, back to you. Thank you very much to our panellists for joining in the conversation.
Thanks, David, and thank you to the panelists from me as well. That was such an engaging conversation, and there's some real nuggets of gold there coming through. And I think for me, the thing that I'm hearing loudly is that to have a sustainable health and care workforce, it's much more than just about sustainable financing. It's about the culture, the leadership, the governance, and everything else that is going to keep people in your workforce. And that is worth investing in, not just the numbers in particular. So I'm just going to end by sharing with you some of our recommendations. So as a result of this forum, as we do every year, we've created some recommendations that we will share with the health ministers. These recommendations will be shared with you as a follow-up to this forum, and there will be an opportunity for you to comment on these. So look out for those coming around, along with the evaluation form as well. And we really appreciate your input. So just very quickly, because we are out of time. So I'm recommendation 1, I'm going to let you read that while it's on screen, but really the focus here is to ask governments to commit to a sustainable long-term financing for their entire health and care social workforce, ensuring they're sufficient in number, integrated across health and social care, and appropriately educated. So I will move on now to number 2. And I'll let you read number 2 on screen here, but really here we're asking governments to commit to initiating formal forward national planning for their health and social care workforce linked to the country's health and social care needs and data profile. And I think this brings in some of the stuff that Lisa's been saying around, you know, looking at breaking down hierarchies and thinking about the actual needs and designing a workforce to meet those. So recommendation 3, I'm just going to share with you on screen here to read. But this is really focused around the commitment to developing and implementing effective retention strategies for the health and care social workforce. And this is everything that's really come out in this panel discussion, particularly around the culture and making sure that workplaces are not toxic and they deal with burnout, bullying and other elements. So we've added an extra recommendation that wasn't actually here previously, and this is really just recognising the current state of play with global health financing. And I think this really goes to just say that we're standing with our countries right now in the difficulties that they're facing, and we really want to call for them to well, we need to, as a Commonwealth network, prioritise the needs of those that are in immediate assistance, and how can the Commonwealth act as a kind of network to facilitate meeting some of these needs. So those are the 4 recommendations we'll be sharing with you, as I said. So it just leaves me to say a huge thank you. So thank you to all of our speakers, to our panelists, to David for chairing the panel, Chamika, thank you so much for all the technical support that you've provided with us. And my biggest thank you goes to Jill Iliff, who is part of our executive and part of the Commonwealth Nurses and Midwives Federation. Jill's been an absolute star behind the scenes, working to pull this off, and I think you'll agree that it's been a fantastic discussion with some amazing speakers, and we really hope that you've enjoyed it. And we look forward to your comments on the recommendations, and hopefully we can write this up as something that will be in the literature as well, which we'd love to see. So thank you very much. I think I've included everybody. David, have I forgotten anybody? Thank you. And yeah, good morning, good night, good evening, wherever you are. Thanks for your participation and for joining us. Goodbye.
Are we just debriefing, or? Oh, Jill's gone. Thank you, Rosemarie. It seems we're all gone.
Thank you.
Thanks very much. Bye.
Bye.